Hello, everyone. Good morning. Thank you for joining us today at this event from PDPAL project, an European project focused on palliative care in Parkinson's disease. Today, we have with us Dr. Andrea Bovero, a psychologist in the field of palliative care and psycho-oncology, and the focus of today's webinar will be loss, grief management, and bereavement. But before leaving the stage to him, I will give just a brief presentation about our project. So PDPAL project is an ongoing project with the focus on palliative care in Parkinson's disease. In fact, PD patients have considerable and mounting unmet physical, psychosocial, and spiritual needs. We have to face some barriers and challenges, and of course, a linguistical one is one of the ones we have to face. In fact, palliative care is linguistically challenging and is often understood as a synonymous to end of life or terminal care. Our ambition is to validate a new model of palliative care that needs to be integrated in the usually management of PD patients, especially in the late stages. Our consortium consists of 10 partners across 7 different European countries, and we have also several partnership and endorsement by other European association and European project as well, like iCarePD. Our objectives are to draft guideline and recommendation to better understand when palliative care needs to be addressed and referred to. We are delivering also a clinical study with a nurse intervention that will aim not only at better addressing clinical symptoms, but will also allow patients and caregivers to think about disease trajectories and disease course. We are also pursuing an educational path that involves creating a massive online open course for patient, caregiver, neurologist, and palliative care specialists, and all students from all healthcare professionals as well. So before leaving the stage to Dr. Andrea Bovero, I will just thank all the partners that are supporting us and the European country as well. So please, Doctor, go ahead.
Okay, I share my presentation. Okay, good morning, everyone. Today I'm going to talk about loss, grief management, and bereavement related to patients with Parkinson's disease and their relatives. Since 2000, I have worked with terminal cancer patients and non-oncological patients in palliative phase and their families. Today, now I want to give you a little background into the prevalence of Parkinson's disease. And as you can see, it emerges as the second most common neurodegenerative disease in older people after Alzheimer's disease. And as you can see from the graphic, Parkinson's disease patients affect around 1 in 500 individuals in the UK, 430,000 Parkinson's disease patients in Italy. Its worldwide prevalence ranges from 1 to 418 per 100,000 people, and it's expected to increase by 50% by 2030. But what is this palliative care approach? The analysis of the literature highlights the need of palliative care approach to help patients with Parkinson's disease and their family. The World Health Organization defined palliative care as an approach that improves the quality of life of patients and their family facing the problems associated with life-threatening illness through the prevention and the relief of suffering by early identification and assessment. It is important focusing on the relief of suffering through the management of physical, psychosocial, and spiritual issues. Palliative care involves a team of professionals that work together. The palliative care team for Parkinson's disease patients includes a neurologist, a palliative physician, a nurse, a psychologist, social worker, and a spiritual guide. And from the graphic, you can see that it is the model of the palliative care approach with Parkinson's disease patients. And it includes the financial, physical, cultural, emotional aspects that are the needs of the patient, but also social, spiritual, occupational, environmental aspects. So this particular approach has to be considered as holistic and model and the global model of care. It is very important to remember that palliative care should not be limited to just the end of life. It is necessary to provide palliative care in a timeline continuing from the diagnosis to the end of life. In this way, all the aspects that we have seen in the previous slide can be taken into account by all the healthcare providers. We need to provide an emotional support to both patient and their caregiver until death and post-death, manage symptoms, in particular the terminal symptoms that were in the last phase of life, for example, pain or depression, give adequate information about the disease, and ensure a good communication about diagnosis, prognosis, advanced care planning between a care provider, patient, and caregiver. It is also important with this patient to evaluate the psychological difficulties. In this article of 2020, depression and anxiety are the most common psychological difficulty in Parkinson's disease patients. And around 40% of the individual might hold concurrent diagnosis. In literature, depression and anxiety are the strongest predictor of quality of life in Parkinson's disease patients. Then other important issues are impulse control disorder, apathy, and some archaic psychosis. Also, all the psychological difficulties could occur at any time through the course of the illness. Sometimes precede formal diagnosis by many years, can be as a disabling as motor symptom, and can represent a key predictor of health-related quality of life in Parkinson's disease patients. Now we can talk more deeply about the differences among the two terms that we use as synonymous: grief, mourning, and bereavement. Let's start with a short definition of the term grief, and it is conceptualized as a primary emotional process of reacting to the loss of a loved one, which focuses on internal intrinsic process of the individual. The reaction can be normal, abnormal, traumatic, pathological, or complicated. With mourning, we refer to a public display of grief that emphasizes the external expression of grief, and it is influenced by mass beliefs, cultural context, and religious practice. Finally, bereavement is the broadest of the three terms, and as the objective situation one faces after having lost an important person near death. In literature, there are various models about the grief process. And Kubler-Ross was the first who introduced a 5-stage model in a famous book on death and dying. This model was based on her work with terminally ill cancer patients, and then has received much criticism in the past because people believe that this is the specific order of the grieving process. At the beginning, denying, then anger, bargaining, depression, finally acceptance. Then Kubler-Ross noted that these stages are not linear, and some people may not experience any of them. In my clinical experience, I saw many patients denial, go through denial phase, anger, and only few people go through the acceptance phase. It is very difficult. It is not now that these 5 stages of grief are the most commonly experienced by grieving people. Previously, we mentioned 2 different individual reactions to loved one death, and we saw that this might be normal, abnormal, complicated, traumatic, or pathological. The most recent version of the clinical guidelines includes a diagnosis of prolonged grief disorder. In Diagnostic Statistical Manual of Mental Disorder and the International Classification Disease. But what's the difference between all of them? For DSM-5, it talks about the persistent complex bereavement disorder when elevated grief continues for 12 months for adults and 6 months for children. ECD-11 focuses on prolonged grief disorder when elevated grief continues 6 months after the death. The American Psychiatric Association considers complicated grief as a psychiatric disorder, and then name it a persistent complex bereavement disorder. And it requires specific criteria for prolonged grief disorder. And the first, that the death at last 12 months ago of a person who was close to the bereaved. And there are 2 important criteria: the intense yearning or longing for the deceased person, then preoccupation with thought on memory of the deceased, and then these things are accompanied by at least 3 of the following 8 symptoms that are identity disruption, disbelief, avoidance of reminder that the person is dead, emotional pain, like anger, sorrow, difficulty with integration into life after the death, numbness, loneliness, and the meaningless. So there are the most important criteria to diagnose persistent complex bereavement disorder. Different clinical tools can be used for better accuracy in the assessment of the complicated grief. The prolonged grief disorder, PG-13, is one of the most used in clinical assessment in the research. If a responder meets the criteria for PGD, he suggests that he should seek a further evaluation by a mental health professional. The cutoff is greater or equal to 35, as you can see on the screen. In the last years, neuroscience has been applied to the grief and loss. The neurocognitive mechanisms involving the complicated grief are currently unknown, but in the study of the professor Mary Frances O'Connor, she hypothesized that the measure neurocognitive difference between complicated grief people or group and non-complicated grief group is that reminder of the disease may still activate neural rewards processing for those who complicate grief may interfere with the daily life. In this study, each participant watches a photo of the deceased lobe during a functional magnetic resonance imaging, and the findings suggest that both complicated grief and non-complicated grief groups may have felt pain during the presentation of the stimuli, but only those with complicated grief also activate an important area for reward processing, that it is nuclear accumbens. The results also show that nuclear accumbens has also been shown to play an important role in the social attachment, such as sibling and maternal affiliation, through the activation of neurotransmitters sympathetic as dopamine and oxytocin. Therapy such pharmacological therapy and as behavioral intervention that target reward processes may confer benefit. Across time, most bereaved people show decreased yearning and increase acceptance. And this is usually an average time, it is after 1 year for the non-complicated grief people. While for complicated grief people, there is no acceptance of the new reality, because to elaborate the loss, it is important for our brain. It is a learning process. The continued reward response to the disease conflicts with the reality of the death. But now let's go back to explore a little bit more other aspects of grief, in particular anticipatory grief. Even if this concept is more studied in relation to cancer and dementia, it can be experienced by every person faced with a life-limiting illness or their loved ones. When compared with grief after death, anticipatory grief has been associated with higher emotional intensity, like anger, loss of emotional control, and the typical grief. And the feeling anticipatory grief does not necessarily lower post-death bereavement. However, several studies show that anticipatory grief has been demonstrated to contribute to the level of burden experienced by caregivers. So that means that a better understanding of the anticipatory grief would be essential to formulate an effective palliative care model. This is a recent study of Fox and their research group about the anticipatory grief in a caregiver of Parkinson's disease patient. And the results show that there are an important relation between anticipatory grief and caregiver burden. The relationship between caregiver burden, depression, and grief is likely to be multidirectional, such that, for example, grief and caregiver burden can lead to depressive symptoms, while depression can worsen feelings of grief and burden. Moreover, this study stresses that palliative care is an approach that focuses on improving the quality of life of Parkinson's disease patients and their family by addressing the attention of the physical, psychological, spiritual needs. And finally, clinicians believe that the assessment and the treatment of anticipatory grief should form part of any palliative care approach for Parkinson's disease patients. We already talked about grief and anticipatory grief, but do we actually lose? We see many different types of losses. loss of personal freedom, autonomy, loss of independence, changing roles, worries about the future, loss of the relationship, loss of some aspects of the personality. Bowlby, an important author, writes that the loss of a loved one is one of the most intensely painful experiences of the life that influences the interpersonal and interpersonal world. So how can we cope with the grief and the emotion related to it? There are some evidence-based treatment for prolonged grief disorder. The most important are complicated grief treatment, prolonged grief cognitive behavioral therapy, family-focused grief therapy, support groups, and psychoeducation intervention. All of these interventions are manualized, time-limited, and focused intervention. First, we talk about complicated grief treatment, that it is a 16-section intervention. TCT showed efficacy in reducing prolonged grief disorder and symptoms in several randomized controlled trials. TCT facilitates adaptation to focus on loss and restoration. To meet the goal of the adaptation, TCT includes 7 core teams that are providing information to help patients understand and accept grief, managing emotional pain and monitoring symptoms, think about the future, reconnecting with others, telling the story of the death, learning to live with a reminder, connecting with memory. These are important tips that the patient talk during the session with the psychotherapist. Very important to reconnecting with the other and to begin a new life. Another evidence-based treatment is a support group that may be preventive intervention to reduce the development of complicated grief. Its primary objective is to improve adaptation and facilitate adequate coping strategies using social support that mediate the association between caregiver grief and psychological well-being. Finally, it is possible to use a psychoeducational intervention that provide access to people who understand and their discovery of the universal aspect of that. In an important study of men, he showed that psychoeducation intervention of the bereaved can provide a means of mitigating complicated grief severity. In particular, psychoeducation programs can benefit individuals with complicated grief, but appropriate support should be integrated into any successful intervention program. An important aspect of an effective strategy in treating Parkinson's disease patients is a multidisciplinary team in a Parkinson's disease patient. In fact, these patients develop motor and non-motor symptoms. So organizing healthcare professionals into multidisciplinary care teams which share clinical decision may improve the overall management of the disease. Then all the members are very important, but their contribution may vary by disease stages and depend on the individual patient needs. And team meetings are an essential tool to build a cross-discipline understanding and cross-discipline education. And finally, a care professional should involve caregiver partners in patient care from the antigen reply. And when the patient doesn't take a caregiver, it is essential to identify a care partner or at least facilitate a conversation about the care role of a care partner. Before finishing, it is necessary to make a mention of COVID-19 pandemic situation that we are still facing, tracing the association with Parkinson's disease patients. As you know, general infection and pandemic-related restrictive situation might exacerbate the severity of motor symptoms of Parkinson's disease patients, increasing patient burden and posing a detrimental effect on quality of life. The most important non-motor symptom of Parkinson's disease patients during COVID-19 pandemic includes fatigue, psychological stress, heightened level of anxiety and depression, sleep disturbance, cognitive complaints. Also, COVID-19 leads to unexpected barriers that force a care provider to under-evaluate psychological and spiritual aspects of their system. For example, patients die in isolation without comfort by their loved one, and both of them losing their rights to end-of-life rights and rights. So there is the need of implementation of palliative care, providing spiritual and psychological support and compassionate communication with family as a potential protective factor to patient dignity and quality of death, and finally promoting their relatives' mental health, for example, reducing the incidence of mood disorder, caregiver burden, post-traumatic stress disorder, or complicated grief. In this study, we analyzed the association between psychosocial factors associated with complicated grief in caregiving during COVID-19 pandemic. The results show that complicated grief was present in 48.4% of caregivers, and then that marital and cohabital status during lockdown, the sense of guilt and depression level were significantly associated with the presence of complicated grief, where attendance at the funeral and social support were found to be important protective factors against complicated grief. So we can conclude that suggestion for strategy promoting recognition of the dignity of the person despite facing death, as well as providing hospitality for the family and personalizing end-of-life patient care and improving family well-being are all crucial aspects in palliative care. We can see the need of palliative care approach to face the patient with Parkinson's disease and their family caregiver issue. This approach enables supportive communication and education about the unfolding illness trajectory and exploration of the family's future supportive needs. In order to provide the best care, professional training is a strategic tool for a care professional and organization. They can acquire new strengths and competencies, expand professional skills in their multidisciplinary field. Thank you. Thank you very much.
Thank you, Andrea, for this very detailed look at the grief, loss, and bereavement. This again kind of stresses how important this area is also, not only for Parkinson's patients, but for all patients and their caregivers, and sometimes also for the teams. Because I think that at your last few slides, they stressed that at times of COVID that were maybe, it is still unstudied, but we know some evidence that it has been a great burden for the healthcare professionals. And I think that there are some bereavement and loss processes that are still, that need to be worked on probably. Maybe you want to comment on that first.
Thank you for this comment, because yes, in palliative care, and now in the last time with COVID-19 pandemic, it is very important for the palliative care team to participate in the psychological meeting for the team, because the risk of burden, especially burnout, is very high. In particular, with COVID-19, the risk is to develop more distress or a compassionate fatigue that the literature shows that is very high in the team that work with COVID patients and also with Parkinson's disease patients at the end of life.
Yes, thank you. And so it is only not for palliative care professionals, but all health and care workers, and they might benefit from supervision and continuous care also for their own psyche. Now, you mentioned a lot also the rituals, end-of-life rituals, and on the other hand, we have Parkinson's disease, where the kind of losses happen much earlier than before death, actually, though, so you called it anticipatory grief. But now, is if you cannot have those rituals like we had during the COVID, or even during the normal stages where people die and people can go to the funeral, but on the next day they have to go to work, are these factors for this kind of prolonged grief and bereavement, so that people just don't have this downtime to think what has happened?
Yeah, yes, this is an important risk factor in the development of complicated grief. In fact, we see that it is very important that bereaved must be able to hold a funeral or to attend the life ceremony at the end of life. During the COVID-19 pandemic, we see the traditional ritual to honor the death and comfort mourning had been interrupted. Family, for example, family members, friends were unable to offer condolences to bereaved person. Another important aspect that I have seen during COVID, for example, is that the inability to see the patient, because there was a traumatic separation from the family. In fact, during COVID-19 pandemic, the patient they were quickly hospitalized, and for many people, for many caregivers, they have no chance to see again their family. This is an important traumatic factor for the development of complicated grief. Another important risk is to develop multiple losses. For example, that either it is a patient, also it is a family, which it is during the assistance of this patient. Another important factor is also to live alone and social isolation. So it is very important that the team provide not only the psychology, but all the team to provide support. And another important characteristic or factor that I have seen during COVID is for this patient family has the ability to receive warmth and affection. And this patient in this world, they were alone. It is very difficult to get affection by their care provider or to have a contact with the family of the community. For this family, it is a risk, a high risk to develop a complicated grief.
Yes, thank you. So now another question, because you are very rare in healthcare with your background, because we do have for oncology patients, psycho-oncologists, but we don't have kind of psycho-neurologist really, although we have the neuroscience, what you mentioned, but and then the question is, because so many Parkinson's patients actually do not have access to palliative care services are people in primary care who maybe visit patients at their homes equipped to support families and patients in grief and bereavement.
Yes, it is a problem, but I think that it is a difficulty not only in Italy, but I think also in Europe. It is because now, for example, there are the European Association of Palliative Care that is developing in the country in Europe, and there is a specific group for neurologic patients, and so also for Parkinson's patients in palliative care phase. But it is very difficult. The collaboration between neurologist and palliative care physician. It is very difficult. The assistance in the collaboration between hospice and palliative care unit, also for this patient. And it is that I think that another important difficulty is that it is a cultural problem. That's to say that the palliative care grow in oncological with oncological patients, and now are developing in other disease as neurological patient, cardiological patient, but it is very difficult to give a training and education for example, for neurologists about for neurology or cardiology for this team. It is very difficult to give education, for example, for psychosocial topics as the communication bad news. So I think that it is the core. It is very important that the team building of the team in which the psychologists talk about it is a psychosocial problem in team, and which the family in different settings, when the patient is recover at home or in hospital or in hospice, when the patient is in these settings.
Yes, so you are speaking from the bottom of my heart, and that's why we are doing these webinars also, to make this information easily accessible to all healthcare providers, so that they can, if they are interested, access those webinars that we have been recording and inform themselves about opportunities and possibilities to support patients and caregivers also emotionally, and recognize then issues if it's complicated and needs some kind of medical support. Because people are sad and people are melancholic, and my fear has been always that also this process, which is very natural, this grief and bereavement process, is being medicalized very often because healthcare professionals don't have time to speak to people. So maybe that would be a last question to me. Do you see that as well?
Yes, it is very important, your question. I think that it is very, for a neurology or palliative physician that work with Parkinson's disease patients, it is very important, very, very important, the discussion with patients and their family about advanced care planning, in which a team talk not only about clinical aspects, but talk about patient preference, talk about the future. It is very important for preparing the family and the patient for the end of life phase. So it is very important to discuss in team with the patient, the family, about the patient's preference. where did you want to stay in the last phase of life, at home, in hospice? It is important to talk about the value of the patient, about his or her spirituality. It is very important, and not that he discuss about his topics with all the team, not only the spiritual guidance psychologist. Another important aspect, I think it is very difficult for the physician, that the patient wants to know if they are neurologist or palliative physician, will still be their doctor until the end of life, even if they do not continue therapy. It is likely to may permit the patient do not feel abandoned by their doctor. It is very important. A research, literature research show that the 80% of the patients wanted to discuss with their physician neurologist about their life, the problem with their family, their concern. For example, the worry about how this loss affects their family. It is very important that the team express empathy, attention, the response to the expression of emotion.
Yes, that is true. And you don't have to comment on this, but I just want to add that also considering children's needs and also preferences to speak or not to speak about what is happening at home should be carefully taken under consideration, because I think that there is a big one colleague referred to it as a can of worms that nobody wants to open, because it is very scary just to speak to children, and the children actually know quite a lot. And so it's again this helping to put the grief and the bereavement into the words, kind of, and verbalize it, what is happening. Yeah. Yes, but it has been absolutely wonderful talking to you. I hope that we will meet also somewhere to face and can continue these discussions. But now, Michaela, you can lead us out of this webinar. And thank you, everyone, for listening.
It's a pleasure for me to discuss with you about this topic. Thank you for the invitation.
Thank you so much.